And welcome everybody to a Tuesday afternoon edition of the Clinical Problem Solvers video morning report. And it is my pleasure to be back on Tuesdays, and I'm here with the great Mengyu, who will be also discussing. And I'll ask Mengyu how things going, how things in your neck of the woods.
Yeah, things are going well. I'm at the end of my maternity leave, so I'm glad I was able to hang out a lot in the past couple of months, but I continue to hang out and so glad to see so many familiar faces today. Oh, I'm always humbled by the cases, like whether it's bread and butter or if it's a complicated one. I feel like, as Sherry was sharing earlier, like I feel like when I got into practice, sometimes my scope became a little bit narrower because the population you see depends on who you see in the hospital. But then I remember when Abraham presented the first case, it was like a transplant, bone marrow transplant patient. I was like, wow, I haven't seen that for a while. So I think I really enjoy this platform as a way to keep my reasoning active. And we're so glad to have Sherry here presenting a case. I think Sherry's presenting the first time, right? So we'd love to get to know you. If you could maybe share, we kind of heard, but if you can share with the broader audience, like where you're from, and what's your passion inside and outside of medicine?
Sure. So, hi everyone. Thanks for having me. It's my first one, so be a little patient with me today. But I am in Georgia. I finished my internal medicine residency in July at Piedmont Athens Regional, and I am currently just finishing taking a break from. Basically, I'm in this like window period of kind of like a gap year, but it's not really a year. I'm just kind of took my time off, just was able to catch up with my family, my friends, and then I was able to like take my board exams, and then I start my actual big girl job in about 2 weeks. So I'll be a non-teaching attending, meaning non-academia, as a nocturnist, and I'm really excited about starting. And me and one of my best friends that we went to residency together will be starting together. She'll be on days and I'll be on nights, so we kind of like swapping together. Some of the things, I'm not originally from Georgia. I actually moved to Georgia right before COVID hit, the first wave of COVID, and I've been in the Atlanta and Athens area since then. I have like a lot of friends from college and who are in the medical field in the Atlanta and Athens area. So I decided to stay, and I have some like distant family as well. And then some of the things I like to do outside, my dog, he's sleeping, but he's over there. I'm hoping he doesn't wake up actually. But his name is Scooby. He'll be one in about 2 days. So I'm really excited about that. And I also plant. Let me see if I can show you. I have about 20 plants. If you can see, that's about maybe 10 of them. And then I have a planter outside, and I also have some plants over there and in my room. I started planting because one of my best friends, we were studying for step three together, and we went to college together, and she was like, "Oh, you should come to my house and let's plant." And then ever since then, I've been addicted. So every time my parents come over, they're like, it's like a forest in here. But yeah, that's really about me though.
All I
Well,
can say about that is fresh oxygen
Yes.
in your place of abode. So you are contributing to the environment, and I think the greenery also has a positive impact
Yes.
on well-being. So I can tell by the way you are and smiling, and
Thanks.
definitely has benefit. I will now, you see my empty office here. I will then bring in some plants. I do need some plants here. All right, let's get going with the case and the first aliquot and the screen. Here we go.
Mm. So I should go ahead and start with the chief complaint.
Yes, please.
Okay, so we have a 25-year-old female that came in for left ear pain and discharge. for the HPI portion. So she's a 25-year-old female with past medical history of neuromyelitis optica. She's on rituximab. She gets that every 6 months, and her last injection was about 3 months prior to coming to the hospital. She was complaining of left ear pain and discharge. She characterized the discharge as yellow and like purulent. So she actually 2 weeks prior to coming to the hospital, she went to urgent care and they gave her Augmentin and steroids. However, due to the pain that was persisting and a fever of about 101 and the pain being like 10 out of 10 throbbing, and it felt like it was almost behind her ear, she decided to come into the emergency department to see if there's anything else that needs to be done.
Oh,
Yeah.
wow. Go ahead, Mengyu. There's such a rich first aliquot.
Yeah, what an amazing start. Actually reminded me of a case I presented to Ravi and Anshitosh, I think, or is it Abraham? Or yeah, we like a patient with ear pain actually turned out to have like a leukemic infiltration, presenting as otitis externa, like malignant otitis externa. So yeah, so I think when it comes to ear pain, like I would start thinking like anatomically, like within the ear, like external ear, the ear canal, like sometimes the infection like with the and then the middle ear, like otitis media, and sometimes the tube, Eustachian tube could also be involved. But most commonly, I think the reflex thinking is otitis media here. But just have to also watch for deeper infections given the significance. And am I hearing like a lack of response to antibiotics as well?
Correct.
So I wonder like what's underlying the process, whether it's some structural issues or malignant issues or like risk factors predisposing to more deeper infections, like osteomyelitis, basically like, or the malignant, that's like along the same spectrum. It's like what kind of risk factors, and then we hear a risk factor, which is the patient's immunocompromised state. So I think that might pose the patient to a very severe infection here. Otherwise, there's like other like inflammatory process that could be at play involving like the ear-eye syndrome kind of spectrum. I'm still curious how the NMO SD the neuromyelitis optica spectrum like is contributing here. I'll kind of have to marinate with that information a little bit. But yeah, those are my thoughts right now. What do you think, Ravi?
Oh, that's absolutely wonderful. I agree with you. There's like, this is screaming number one, number two, number three. There's maybe an infectious process. And there was a case a while back, I think me and Kirtan had that tackled that case, and it ended up being, I'm forgetting the diagnosis, but it was a autoimmune phenomena. But then I learned, so I was not very good at maybe determining a mechanism of ear pain. But what I learned from that case, like with every case, you learn an approach. Maybe your illness script is not as good, but then you perfect it with each experience on CPS. So what I learned was I usually, with ear pain, I think about primary and secondary causes. In my research, the primary causes are any sort of pain that comes from the ear. Most common causes for pain that's coming from the ear, primary otalgia, is going to be otitis media, otitis externa, which we talked about. And that's pain that's usually continuous, it worsens, and it's usually associated with primary otalgia. So secondary otalgia is going to be that's otalgia. That's the pain that originates from outside. So primary is from the ear itself, and then outside the ear is secondary. And that the most common cause of that is going to be anything around the ear, like your temporomandibular joint and the syndrome associated with it. Dental infections can be associated with it. And there are many other things, cranial nerve disorders, also cervical spinal disorders can also radiate there as well. Choroidinia, cervical spinal stenosis, things like that, oral aphthous ulcers, thyroiditis. So an exam to really help delineate this, and I think Sherry's going to go through an exam, but just to try and determine the exam of the ear, you're going to at least promote traction of the auricle, see if the pain is elucidated by that. Palpate the tragus to differentiate disease process affecting the external ear or internal ear. Then you're going to use your otoscope, and in every emergency room, they usually have an otoscope that's on the wall. Then also doing an oral exam to look for any dental abscesses or infections or aphthous ulcers. Then also palpating the temporomandibular joint, and then also head, neck, and cervical spine. And through that, you should be able to determine, is this within the ear or outside, or structures that are outside the ear that could be plaguing this person's ear pain. And then breaking down primary here, like Mengyu had mentioned, this infection is very concerning. And what you start thinking about with primary altalgia, not only infections, but neoplastic. Mengyu had talked about the leukemia, the case of the leukemic infiltration, any inflammation, autoimmune disorders, so like GPA, relapsing polychondritis. That was the case, right? Relapsing polychondritis was the case with Gittin. And then also mechanical things like Schrumann impaction. Or you see these really great videos on Twitter of people removing spiders and insects and things. I actually removed a cockroach from a patient's ear once who had trouble, couldn't hear. And then also barotrauma and eustachian tube dysfunction. So that's sort of like a whirlwind ear pain sort of approach, but we'll see what Sherry has in store for us. And yeah, this background, right, Mengyu, this background of the neuromyelitis optica, you started talking about brain, ear, eye syndromes, and neuromyelitis optica usually doesn't involve the ear. So I'm wondering, does the rituximab have any involvement with this? Does it predispose the patient to having immunocompromised status? Possibly. So it could be a really nasty infection if we think about it. But anything else come to mind rather than I'm rambling on?
Not right now. Yeah, I think most likely this immunosuppression is contributing to or playing the major role here. Although like my mind also went to like, is it part of the same process? But I think given the like the ear eye, but I think given the acuity, I think still primarily is the external or the anatomical structure being inflamed or infected is the primary concern here.
Mhm.
Okay, great. We'll swing it back to Sherry for the next aliquot.
Sure. So with her past medical history, as I stated before, she has neuromyelitis optica. She's on rituximab. The other medications that she is also received was the augmentin and the prednisone taper. The prednisone taper was a max dose of 20 milligrams over, I believe, like a week. It wasn't like a continuous steroid. As far as any other medication, she's not on any. As far as her family history, it was non-contributory. In her social history, she did not smoke, drink alcohol, or anything. And then for her allergies, she didn't have any. So literally all I had was left ear pain, immunocompromised, and non-responsive to antibiotics and steroids.
Yeah, actually, let's stop there. That's a very interesting point that you brought up, Sherry. So steroids, the other thing, this patient is epidemiologically not within the framework of maybe like a temporal arteritis, vasculitis/vasculitis. So steroids sometimes can be a therapeutic and also diagnostic intervention. But here, again, with steroids, it didn't improve. So likely less of the immunoinflammatory variant or etiology, unless the dose of steroid is not high enough to tackle an immune dysfunction. But then the antibiotics, augmentin's a fantastic antibiotic. It will cover anaerobes, gram-negs, gram-positives, MSSA, except Pseudomonas. I don't think this patient has. Would there be a risk for Pseudomonas infection in the ear? Augmentin likely wouldn't be helpful. What else? Enterococcus it can cover as well. And so it would be a fantastic first line choice for your garden variety ear infections, but non-responsive to this. Maybe we're dealing with a complication or maybe a bacteria that is not covered by this antibiotic. Any ideas, Mengyu, with this information?
Yeah, I feel like we're entering the framework of like antibiotic failure, as you said, whether we are not, first it could be incorrect diagnosis, but I think we have to really look deep into the infections first, and then so we have source control. So maybe there's bone involvement, like needs surgical drainage or intervention or something. I think imaging and ear otoscopy here will be vital, and then maybe and then maybe inadequate coverage, as you said, like if Pseudomonas is involved, then we need to really broaden or use more aggressive antibiotics, and making sure, I think we could assume the patient is taking the medication with the correct dose. So yeah, those are my thoughts right now. I
Yeah,
really
also,
want the imaging and exam. I think that would
yeah,
be.
I think that will be key. You're absolutely right. What's interesting in the chat, I'm scanning, like Solson's mentioned, two other things. We usually see these photos of patients with ear pain and the much commonly seen Ramsay-Hunt syndrome. They usually love on these step questions or herpes zoster. Sometimes we do see those. So those are two sort of infections that you usually will see with an examination. So I think key is, like you mentioned, exam, and then the next is the otoscope finding. So I'll swing the mic back to Sherry.
Okay. So with the physical exam, her vital signs, her blood pressure she was normotensive. She was right around 119/72. Her temperature was 98 initially, then I believe it went to 101. And then her oxygen was about 100% on room air. Her heart rate was about 103 and respiratory rate was about 16. Far as her physical exam, she looked uncomfortable, but she didn't necessarily look unwell. She was just looking very uncomfortable, not necessarily diaphoretic or any like respiratory distress or anything of that nature. However, she just looked very uncomfortable. She didn't have any rashes that I could see anywhere over her body, head to toe. Nothing was there. Like I know someone was asking about like Ramsay-Hunt syndrome, things of that nature. She didn't have like any like facial droop or proptosis or anything of that nature. And as far as her head was concerned, it was normocephalic atraumatic. And as far as her ear was concerned, she did have some pain on her tragus, but the pain was more so inside the ear than on the that was more concerning for otitis media versus otitis externa. So when we looked inside the ear, there was some discharge out of it. There was that yellow discharge that she had, but there was nothing that I could pinpoint to say that it was an issue that I could see with my eyes. As far as her oral cavity was fine. She didn't have cavities. There was no dental abscess. She had no issues with her TMJ. As far as her nasal turbinates, there was no like swelling. There was no postnasal drip. Her eyes were equal, round, and reactive. She was alert and oriented as well. And as far as her cardiac, abdomen, and her lungs, those were clear and was within normal limits. So the only thing that was really pertinent was still which was her chief complaint, was the pain in her ear, as well as the yellow discharge that we could see. There was cone of light, but there was no, I think someone asked about colostoma. There was nothing of that nature as well. And she also, I forgot to say earlier, she denied any trauma to the area, and she also remained adherent to her medications.
Yeah, wow. Wow, what an interesting story. Really curious what's happening. So it sounds like the exam, like so far, really kind of help us kind of anchor on the otitis media. And then so when traditionally, like we think it's bacterial and it's not improving. So I wonder if like surgical intervention is needed for that. I think an imaging will be a first start. followed by potential ENT consultation. But also I'm like trying to think more beyond the base rate. So like in my like framework of like recurrent or the unconventional otitis media, there's like definitely those inflammatory syndromes at play, could be at play, like a GPA or like Behçet's or relapsing polychondritis. I think I'm probably, or even Vexus, but I think I'm probably going to Zebra because the patient already had a neuromyelitic, like, and I'm also like trying to think those whether vasculitis is I don't think they're that closely like associated in terms of I guess maybe some vasculitis could cause the spectrum. I have to double check on that. But then also like if there's like a viral process, maybe then the virus has to be treated as another potential cause for this persistence, like people mentioned in the chat. Yeah, so I think those are the things that I'm thinking about, like potential need for surgical intervention or deep bone infection versus another underlying process, or a different infection. Yeah, what do you think, Ravi?
Absolutely. I wholeheartedly agree with you there. This is very concerning, but I just want to make a comment. Sherry, for your first presentation, this is marvelous. You're doing a fantastic job. You're so effortlessly just producing the information, not even reading off your paper, but looking into the screen. So I just got to give you kudos in regards to that. So yeah, I'm excited for the next batch of cases that you bring from your nocturnal shifts. But again, this is not the routine thing, Mengyu, that we get patients with ear pain. I've been stuck by this before, like I told you, relapsing polychondritis. But the great Rafael Medina actually presented that case, I remember, long ago. And so getting back to this case, you're right. I'm like, there's some really interesting comments, great questions. Like number one, like why can't we culture the drainage that's coming from there? But like anything, if it's not from an enclosed source, you're gonna culture whatever the material was in contact with. So if you have anything external to the ear, any passengers will be picked up, and you may get a false positive culture, and then you may treat the wrong organism. So you want to open up an area like an abscess and directly then drain and obtain the material. That way you get the organism that's causing this infection rather than a passenger that's lining the airway. At this point, I think the most common cause is going to be bacterial, yeah, viral etiologies as well. I've also, Sherry, a great exam of the year as well. I just love what you mentioned, especially when we went through how to examine the ear to determine if it's primary, secondary, external, internal, and you went through pulling the tragus and so on. So this, with the pain being very continuous, this patient is appearing very sick, right? There's a temperature, although the patient's immunocompromised, they may not be able to mount a massive febrile response, but the heart rate is up, the blood pressure's teetering right on the edge. For a healthy 25-year-old, your heart rate should be lower, blood pressure maybe not this low. Oxygen saturation is fine. So this is not something, with the head and neck, some of these infections can drain down into the chest sometimes or to the brain. So they do move from the jaw and so on to the brain or down into the thoracic cavity. And maybe you pose an interesting question with this NMO, and I'm not getting a flavor of this NMO really acting up the neurological exam. There's nothing there with the NMO there. So this is probably a separate entity, and the only relationship between both of these could be the medication that is causing immunosuppression. So at this point, augmentin prednisone hasn't really worked. Steroids, 20 milligram taper. Do you remember, Sherry, what was the initiating dose of steroids? Was it 60, 40?
I just know that the max wasn't over 20. I don't remember.
Okay. So if it's inflammatory, somewhat inflammatory, may respond. Sometimes the dose is not enough. We had a case yesterday of a patient having dermatological findings, which ended up being, I won't say the diagnosis in case the person wants to present, but the steroids were not of a high enough dose to really impact it. So empiric steroids were given and it didn't do anything. So it can be kind of rudimentary to say that the steroid's not going to help this, whereas a much larger dose may be helpful in trying to tame this. And in certain disease or illnesses, it can also be diagnostic, like temporal arteritis. If there's a response, you can, without even getting the temporal artery biopsy, you can say that this likely is this if your pretest probability is high enough. So at this point, yeah, I think a lot of people are mentioning what's the white count. If the white count is a nice elevated white count with increased neutrophils, we could say, let's change the antibiotics to something different. So you never want to give the same antibiotic or the same coverage, but you want to, like Mengyu mentioned, antibiotic failure. But then I'm wondering, imaging. I'm worried about something deeper into the ear, and that is non-responsive. The patient's looking very sick, and then you have to worry about dissemination. Maybe this is the starting point of an infection, and it's moved into the blood, is moved into secondary organs. You have to start wondering about that. So I'll kind of leave it there, and I'm eagerly anticipating the labs.
Yeah, and I think if I need despite all these like thoughts, I think the primary concern is still like a deeper infection, especially a bone involved, like a mastoiditis, as people mentioned in the chat, like an involvement of bone, like so IV antibiotics might be really what the patient also needs, which is lacking here. So yeah, really look forward to the imaging and labs.
That's awesome. I think those are also really good things to look at as well, because the main concern was, you have a young patient, immunocompromised, they're not responding to the go-to antibiotics with Augmentin, with otitis media, and they just generally don't look well. So what exactly am I missing in regards to that? So let's go ahead and jump into the labs first. So the labs, so this time I'm going to actually have to look because I don't remember all the labs. So for the labs, we have the white blood cell count was 19, with a neutrophil predominant at 87. The hemoglobin was 12. The MCV was 81. Platelets were 406. The sodium was 141. Potassium was 3.9. Bicarb was 31. The calculated anion gap was 13. BUN was 14. Creatinine was 0.6. And lactate was 1. The CRP was 2.57. And at that time, it was really basically her BMP was fairly unremarkable. Her lactate wasn't high. So even though she had a little bit of a soft blood pressure and she was tachycardic, we didn't really necessarily think she had septic shock. But that there's different types of septic shock, but at this time was like more concerning for a patient that had a bacterial infection that could possibly be missing. So at that time, we didn't do like troponins. EKG was normal sinus rhythm, other than the tachycardia that was picked up. And the chest X-ray, we didn't bother with chest X-ray, but we went straight to CT head because we were concerned that there could have been an underlying infection that we cannot see on the physical SAM that's either in the bone. Is there an abscess there? Is there something behind the eardrum that we cannot necessarily see? So we actually went with the CT head. Should I go ahead and talk about the CT head?
I think I'm interested. Maggie, you want to take the labs? I think we were anticipating something like this, but I'd like to hear what you think about this.
Yeah, I think the labs is what we would expect in what we see earlier from the history. I think with a high white count, neutrophil predominance, and elevated platelet, again suggesting inflammation. I think all consistent with what we are worried about. Although I'm curious why the CRP is. I would expect like a CRP of 200, but I would not use that to deviate what I'm thinking. Yeah.
Yeah, absolutely. I think at this point, if we were seeing this patient in the emergency room, and imaging would take a little while to come back, especially the interpretation, unless you're well read in being able to dissect the CT of the brain head. and neck. I think this is enough. This has given us enough pretest probability for initiating antibiotics. We're at the therapeutic threshold to start some therapy, and this just confirms it. Yeah, the CRP is interesting. I guess CRP takes time to rev up, so you may see the CRP just jump in the next day because this is quite early in the process. I'm sure the SED rate will be elevated initially because it does differentiate between acute and like sort of subacute chronic infection, inflammation. So what would you? I think a couple of people have put down antibiotics. What would you do, Mengyu, at this point?
Yeah, that's a good question. I think I would cover broadly given her immunocompromised state. So definitely cover Pseudomonas, MRSA. So we'll use big guns like vancomycin or vancomycin.
Yeah, I think so too. There's because the patient has been in the healthcare setting, has got antibiotics recently, right? Already, which doesn't cover MRSA, Pseudomonas. So I agree. So cover broadly anaerobes again and Pseudomonas, and people have mentioned Vanc and Zosyn. Although we're seeing in some institutions Zosyn has emerging resistance, so you could go to maybe Avicaz or Zerbexa or even cefepime. But to the cefepime, you'll have to add anaerobic coverage. I still would cover anaerobes in case because of patient isn't diabetic, but there is a tendency to have anaerobes causing infection in this area. All right, back to you, Sherry.
Sure. So I'll talk about the CT head first. So with the CT head, there was actually near complete opacification of the left mastoid, and there was a middle ear cavity, which was basically compatible with mastoiditis. So at that point, we had already started broad spectrum antibiotics, as you guys have rightfully stated, with covering Pseudomonas as well as MRSA, especially in a patient that's immunocompromised. And we went ahead and called ENT and our surgical specialist so she could undergo surgical debridement. But that's only the beginning of this story.
Oh my gosh, Sherry, the roller coaster ride is not over yet. You're gonna probably put us in an upside down spin. So the CT of the head, the pacification, yeah, I think that just shows great management or planning when you have something like this and patient you have this very toxic appearing patient in front of you, especially a young patient. Yeah, young patients tend to scare me because they can compensate up to a certain amount before they start really showing that they're very ill. So you have to treat them very differently. We always wonder, maybe a more senior patient may actually will be able to compensate to a certain degree and then show that they're really in distress. But a young patient I've seen can give you this false sense of reassurance that I'm doing okay, this patient's doing okay, but then suddenly they can deteriorate very rapidly. So with this patient, yeah, getting all hands on deck, getting ENT, I think is definitely a good option. And the antibiotics, like you had mentioned, and what was discussed, especially what I appreciated in the chat, was will MRI be helpful at this point? I'm not sure, but I would like to seek the opinion or what the opinion that ENT had given you, maybe by treating the left mastoid, this opacification, draining it, and then seeing what kind of residual finding there would be. Unless this has progressed to bacteremia or spread to a distant organ through hematogenous spread or contiguous spread and so on, if there's osteomyelitis and so on. What do you think, Mengyu, at this point?
Yeah, I'm curious what turns Sherry will share with us in the next few hours. But I feel like we're doing like things correctly like so far, but I'm wondering if some complications will happen either as a result of mastoiditis, like there could be venous sinus thrombosis or epidural abscess or CNS involvement, and yeah, but so far I don't see other things on the imaging like a tumor underlying. I don't see that, so I'm curious if some complication is what we're expecting.
Okay, so so what's even more funny about, well, not necessarily funny, but what is interesting is that this was my last like 6 months as a resident. So they kind of put you in a position where you're the attending, you're the one that's really like calling the shots. So this was like very interesting for me to have this as basically she was my patient. And so I was the one that had to do all the shots and all of that nature. So that brings me to the morning after the surgical debridement. And I walked in the room and I asked her like how she was doing. She said that, initially that the pain after the surgery was getting better, but she noticed that the area near the surgical incision was kind of swollen. So I looked at it, I did a full physical exam. Her vital signs, she was normotensive, she was no longer tachycardic. Her physical exam was fairly unremarkable, except for she had the gauze where ENT and the surgical team had took care of it and drained it. And it was a little bit swollen. And I'm not going to pretend that I'm a surgeon, so I'm going to have them come look at it for me. So I had them come by and take a look at it just to make sure that the swelling and the pain was just from the surgical area, and that was normal for post-op. So, they come and look at her, they say, it's fine, this is post-op, there's really nothing else for us to do. Let's continue with the regimen that we have until the blood cultures and the wound cultures come back. So something told me, before I leave, go back and make sure that she's okay. So I go back and the swelling is a lot more, it's a lot worse. So she sits up and blood shoots out of her ear. And I'm like, okay, let me call ENT now and call surgery right now, their NPO, and make sure that this is just too much blood. It wasn't like just dripping, it was just literally shooting out of her ear. So I called ENT, they came back, and the next thing they took her down back to surgery. And at that time, when they were in the surgery, they found that under the temporalis muscle that there was an artery that was bleeding, and that was the artery that was shooting out of her ear. So,
Wow. Well, first, kudos to you for managing such acute scenarios with calm and appropriate involvement of, people who needs to be there. So like kudos. And although I'm like also really definitely like nerve-wracking moments on the wards.
yeah.
So I'm curious, is that a complication of surgery where maybe an artery was injured?
Yes.
Yeah.
Yes, just because of where the mastoiditis was and the temporalis muscle, it kind of got nicked. And initially with the type of bleeding, it's supposed to basically cauterize itself, but in her case, it did not. So they actually had to take her back down to get it cauterized. And then when she came back up, she was fine. But of course, that wasn't the end of the story either.
Wow.
Yeah, I just want to comment. Sherry just mentioned that is so important that sometimes I don't know what it is. It was like divine intervention or whatever, gut instinct, but there's many cases where you're like, hey, let me go just check on this patient again. Something's maybe sparking your interest or curiosity. Something's not right. And I've had that many times, and I've gone to see patients 8 times sometimes. And yes, yeah, we're busy with life and other things and activities, but sometimes that revisitation can be vital because patients aren't just static. They don't just come in with their index condition, but it can evolve over the course of their hospitalization. They can get better or they can get worse. And sometimes it's not obvious. You have diagnostic dilemmas which may be exposed or may become apparent during the hospitalization. So many times I've been saved by my gut instinct, and sometimes the outcome can be horrifying. It's not something that you were anticipating, but it's very important, I think, on your daily list. And I always tell my interns, check if something's not right or something you're worried about, and just circle and go back and see that patient again. And if need be, go again. And that can sometimes save the person from a adverse outcome. But I just want to give you kudos on that. That's amazing.
But the story's not over. So it was the day after, and I've always felt that, I've always felt that with medicine, sometimes it's always best to do it as a team. Your nurses are part of your team. Your specialty support is always a part of your team. So I decided that I was going to put all the specialty support in one group chat on Epic so everyone could be on the same page. Because at that point, as someone stated before, that they were concerned that maybe that this was a neuromyelitis optica flare. Neuro said, no, it's not. Then we had ENT in the surgical team with the mastoiditis, and then we also had ID. And with the cultures, the blood cultures were negative, and the drainage from the ear actually grew Marxarella cataracts. So by that time, we were like, okay, we're getting headway. Let's go ahead and start de-escalating antibiotics. It's not Pseudomonas, so let's get rid of the Zosyn, or the cefepime that we have. Let's get rid of that and start to tail down. So at that point, I thought that, we were making headway. Her vital signs were stable. Her leukocytosis was going back into normal range. The CRP initially, as I think someone else stated that they were surprised that the CRP was so low. I was too, but at the same time, she's also immunocompromised. But during that hospitalization, it did go up, but it came back down. So at that point, I thought, okay, like, this is great. We're going to keep moving forward, and I'm taking care of my patient. However, I told the nurse, because I don't know what it is. Sometimes, like, you just kind of like tell people, like, I'm really worried about this patient. She's someone that I'm really worried about. If anything happens, if I'm not here, call me and I'll come back to the hospital to see her myself, because she's such a complex case that if something were to happen, they may not understand everything that happened beforehand and who to get in contact with. So the night, it was like 7, 8 o'clock. Nurse calls me like, hi, Dr. Walls. I know, like, you're not here, but I'm concerned. The patient is stating that she's seeing double. I'm like, double, like as in like 2 people, like there's 1 person and 2, or is it like, is it some type of aura? Because it's like neuromyelitis optica. Is she getting ready to have? She's like, no, it's completely different. So I called my attending. I said, I'm going back to the hospital. And I told my one of my best friends was my neighbor. I was like, take care of my dog. I'll be right back. So I left and I went to the hospital and I examined her, and she indeed had double vision. She had diplopia. And at that time, she had mild proptosis of the eye that was involved. So I said, let's go ahead and call. I don't think it's a stroke, but let's go ahead and call the stroke team. Let's get her down to get teleneurology to be seen, because I'm concerned. I'm least concerned that this is a stroke, but I'm more concerned, is this like a venous thrombosis? Because the mastoiditis, they did a surgery there. Is there some type of thrombus that's causing this diplopia? What is going on? So we took her down. We got to teleneurology, and I explained my reasoning of, I told him about the patient. We did the physical exam. He said, she's not a candidate for TPA, which was fine because I didn't want TPA. I wanted a concise thing that would tell me, is this patient having a thrombus in their head that's causing the diplopia? So we decided through shared decision making that, okay, we're not going to do the CT. We don't think that it's a stroke. We think that there could be some type of thrombus that's a complication of this infection. So we decided to get the MRI brain, because the T1 contrasted images are better at looking at the venous sinuses. So when we got it, I'll let her bring up that image. But when we got it, that basically I was right. There was a small venous thrombosis on the left mastoid that was starting to propagate into the area where it was. And that was what was causing her the diplopia. So at that point, I had to basically kind of will back and go to part one of kind of like, okay, well, we thought we were in front of it, but now it's basically a complication of the mastoiditis. And so what we ended up doing is we got her to like a tertiary center to Piedmont Augusta, which is basically our brothers and sisters that live like maybe an hour or two to see like some of the vascular specialists if they need to do a thrombectomy, because at that point she was already on heparin, then we switched her to aspirin, and vascular saw her. We did the antibiotics. It was Marxella. It was covering the antibiotics. So at that point, we had a discussion with all the team members and the family and her, and we decided that we would get her to a tertiary center. So that was the end of my roller coaster.
Wow, thank you, Sherry, for taking us through such a journey. And really, I was impressed with every level at every level. I think you basically exemplified uh everything, like including your awesome communication with like the multidisciplinary team, close loop communication, but also like your astute clinical judgment and diagnosis with the concern of sinus thrombosis as the cause, and communicating with radiologists about your concerns so we can get the right study. So I think really kudos to managing this patient. Patient is lucky to have you being her almost attending level.
Thank
uh,
you.
provider.
Yeah, I also agree. Yeah, yeah. And Mengyu, great thought. You earlier on in the case you thought about venous sinus thrombosis. So excellent suggestion there. And Sherry, wow, you presented this case almost like a story, and with so many twists and turns, and your ability to present is just amazing. And I hope you bring more cases you'll see on Night Float. And I'm excited that with the management that you displayed here, you are ready for independent practice and
Thank
ready to
you.
take on Night Float. So, yeah, I mean, I don't think I could manage it in any different. And you presented a textbook way of managing a patient like this, in addition to your gut instinct to go back and look at this patient because something's not right, and even coming from home to examine this patient. So, do you know what happened at the tertiary center? Like, how did the patient like the with the eye findings? Did the diplopia improve?
So I know that so that was between the time that Piedmont was kind of taking over the hospital. So I can't necessarily see everything that happened, but I did see that she followed up with her primary neurologist and that she was doing physical therapy, because which I kind of left out, but because of where the surgery was, she also actually had cranial nerve 12 irritation where she would have dysarthria, where she couldn't really talk. So she actually went to physical therapy to learn how to talk again, just because of the cranial nerve 12 inflammation from all of the surgery and all of that. But the diplopia improved from what I could see and gather indirectly, but I didn't have like a full like go through each note where I could see. But from what I could see is that she improved at the tertiary center.
Awesome, awesome. You definitely, a lot of this is due to your ability to identify this complication and get it to where she could get help and prevent any long-term complications. So again, kudos to your fantastic management and also a great presentation. I really enjoyed this. And thanks, Julia, for scribing and teaching points. Vinicius, appreciate if you could take it away.
Okay, so I'll be brief. And the first thing that we learn is about the anatomical approach that we need to have related to a patient that presents with external ear pain. So we need to think this is an internal or external, and it's referring to the tympanic membrane or to the ear canal, and this could be disseminated involving the middle ear and bones. So osteomyelitis could be on our differential, and deep tissue infection could be also. And besides this, we need to consider structural issues, malignancy, and also cholesteatoma. Ravi talked about some possible etiologies of some ear-eye syndrome, and it's a spectrum. Besides, we need to ask ourselves what are the risk factor and the immune status of these patients, and we need to proceed. This is irradiating to the ear, or is it primarily issue in the ear? So we'll divide in primary versus secondary causes, and being the primary ophthalmia, being medial or external, and consider pseudomonas to that. And the secondary issues we'll consider things that are related to outside of the ear. And so cranial nerves should be evaluated, and the ATM should be evaluated. And we need to consider cervical spinal stenosis, thyroiditis, vascular issues, and finally, a Ramsay-Hunt syndrome. Other points that we'll evaluate is about the pain pattern and proceed with the physical evaluation. The physical evaluation will compose the initial visual evaluation, and proceed with the otoscope, see how is the tympanic membrane, if there is any kind of cerumen impaction or any inflammatory signals, the uro examination, if there is any presence of abscesses, ulcers. Palpate, we need to palpate the temporomandibular joints, evaluate, as I said, cranial nerves, and see if there's any vascles that could suggest zoster eruptions, if there is any hearing loss, doses, nasal or sinus examination. And we need to also consider less common causes such as leukemia, inflammations providing from vasculitis, GCA, GPA, or even Behçet's, parathyroiditis, sarcoidosis, even polychondritis. After we have all of these spectrum evaluated, we'll proceed with the imaging evaluation, and the CT can provide us with a good visualization of the bone. We will also consider venous sinus thrombosis or brain infiltration, and even the MRI could be done to evaluate the jugular venous sheath that could suggest a linear disease, syndrome infection. Yep. So after that, we'll consider if surgical evaluation is needed, and we need to correlate that with dissemination if there is any kind of blood or lymphatics or continuous evaluation, and all of that could lead to sepsis. Mastoiditis is it's also in our point of view, because it need to be ruled out, and we will proceed with surgical debridement if this is present. So our patient was revealed to have a neuromyelitis optica X spectrum disorder, and we need to consider if this is a flare, and also what is the pretest probability of all this conjuncture of symptoms that the patient is presenting, and we can see that it is infection. So we need to initiate antibiotics right away. And if there's no response to initial antibiotics, we need to escalate them without any delay. So we need to cover MRSA, Pseudomonas, Vanco, plus cefepime or Zosyn, and even anaerobes. And finally, our patient was revealed to have venous sinus thrombosis, and a thrombectomy should be done, or the risks and benefits should be taken into account. So that's all. Thank you for the case.
Thank you, Vinny. That was marvelous. You're doing a fantastic job. It's almost like a lecture on the whole case today. And Sherry, I don't know if you saw, there's so much appreciation for you and your case and the learning, and not only the way to approach a patient like this. Any parting words of wisdom before we leave?
Sure. I'm trying to read all of the messages, but thank you guys so much. I really appreciate it. I would just say, in general, the thing that I really live by is that your journey is your journey, and just really being able to not compare yourself to others. You're not always going to be the smartest in the room. You're not always going to be that 95 percentile, ITE, ABIM, whichever exam, but being a physician is so much more than an exam. It's so much more than just being able to meet qualifications, but actually being there for your patients, being there with their families, and making a collaborative approach to medicine is the best part. And I honestly feel like this was the case that really pushed me more to feel that it's okay to be independent. It's okay to trust your gut because you know the stuff. You spent all this time studying, you spent all this time mentoring and doing all these things and helping other residents. It's your time to step in that and to not compare yourself to others because everyone's journey is different and you're more than capable of doing what you ultimately want to do. So.
Wow, I couldn't have said anything like that better than what you said. And yeah, VMR, where you learn medicine and also learn about life in medicine and the joy of medicine. So Mengyu, thank you for co-discussing and great job on getting the final DX. So thank you, everybody. Have
Thank
a
you.
great rest of your Tuesday. Bye. Thank you.